Good afternoon, teachers and my dear respected friends. So today I'm going to talk about PDA
What
device
again
closure by
PDD?
Eco Guidance. So PDA constitutes around 5 to 10% of all congenital heart defects. Prevalence of the symptomatic PDA being zero point 0.5 per thousand live births. The first transcatheter closure of PDA was reported by Portsman et al. In 1971, and from that time onwards, it is being used practically and every time. So fluoroscopy guided device closure, echocardiography guided PDA device closure has been practiced nowadays. Few centers did exclusive echo guided and some with minimal fluoroscopy guided. So requirements of echocardiography for PTA. So pre-operatively for assessment, we need a four-chamber view, a plaques view, at least these things. A high parasternal view to look at the PDA and the type, and the arch view to look at the type of the PDAs. Perioperatively subcostal view to see the IVC and the RA junctions so that the catheter can be advanced up to that. The bicaval view in which we can address and proceed with the catheter up to the RA and RB, and from there after going upstairs and then we go to the PSAX view, the ductal view and the arch view. Post-operative assessment, the ductal view and the arch view and the four chamber view for the assessment. So pre-operative evaluation. So let's go first one. And so from the after the all the assessment has been done, that is the situs solitus and all other has been evaluated. So from the four chamber view we get the dilated LA and LV. So when we get a dilated LA and LV, we are things which comes to our mind whether there is a left to right shunts which are there. Now from the Plaques view, if you get an LA-AO ratio which is very high, around more than 1.5, then you see that it is a post duct around the aorta, PTA or APA windows which are there. And from the arch, if you see the arch is dilated, then it is goes to the AP window. Now from the ductal view, which we see that the PDA is there, and from it a continuous flow patterns can be delineated. If you get a continuous play pattern, this also delineates to help to assess the pulmonary pressures which is there. If we get a continuous pressures which are diastolic is high, so that PA pressures are low. These two things helps in us assessing. So from this we get to measure, and from this modified PSAX view we also get to view the PDA and measure it. So intraoperatively, various papers has been done. Eco-guided percutaneous PDA closure, which was a 1-year single center study in Indonesia, which did use TT transthoracic as well as a TE mod, in which they proceeded up to the transthoracic, used for the progress up to the IVC and to the RA they used, and then they did the TE. And it was all pressure guided, which was being used. From RA, they then proceeded from the tricuspid valve. They rotated it, and it was in the 90 degrees, and then rotated up towards the tricuspid valve, and then proceeded further to move into the RV. And from the RV, it again moved to the RV to the PA, PSAX view 90 degrees, and with the pressure tracings, which helped to assess whether it was in RV or the PA. So from then, with the suprasternal arch view, we can see the device, and with the pressure tracings, we gradually pulled up and then placed, and thereby could view the PDA device. So even in the retrograde, we can see up to the aorta, descending aorta, and then crossed it in the arch views, and then can help it to some extent. And in the high parasternal short axis view. This was a paper which was done from the China, which showed they used transesophageal, exclusively TE guided, to do the PDA device closure without using a fluoroscopy. And they initially did the 91-25 bicaval view, and from there, after going to the tricuspid, they went into the RV, and from RV to PF by moving into the 60 degrees view, and from there, from 60s to then again into the 125 degrees. So post-operative on table, we usually evaluate at 1 month, 6 months, or 1 year. And ductal view, which we look for device position, where there is leakage, peri or through device, LP obstruction, turbulence, pulmonary valve status. Because LP-RP stenosis, if it is present, especially it is common in the small children's. And suprasternal arch view to look for any coarctation. Specifically, it is more common in the large PDAs if present in the small babies. And what to look for the four-chamber view in the post-operative PDA closure? It's mainly the chamber function. In many of the patients can have LV dysfunction post-closure. The chamber size regression doesn't occur quickly. It is the spacity and which you can see in the follow-up, a 3-month or 6-month follow-up, which can regress. The tricuspid valve, whether any injury has been done or not, and mitral valve, as well already has sent the mitral valve, whether regurgitations which were there due to the dilatation, with the has decreased. So in our institute, we did a comparative study to evaluate the radiation exposure in patent ductus arterius device closure by conventional method and echocardiography guided method, where we compared the radiation exposure and the procedural time with the transthoracic at the minimal, and we did exclusive echocardiography. We used minimal fluoroscopy because for the RV to PA crossing, we used the fluoroscopy at that time. All children between 6 months to 12 years were included, a detailed echocardiography, and from the echocardiography +2 to +4 was device size was selected, and devices where ADO or the LifeTech was included. After the femoral venous access, we proceeded from the subcostal view and ARA, and then we entered by the ECG guided. From the ECG guided, when we saw PVCs, we were there in the RV were fixed. And then by minimal fluoroscopy usage, we crossed up to the pulmonary, and then with the help of the echocardiography, we placed them. And further, the device deployment from the echocardiographic view. So to conclusion from that, there was fluoroscopy time was very less, procedural time was minimal because only venous access was done. And even in small patients, it was very good without, even in many patients, we don't nowadays use any arterial access. And the amount of radiation exposure was minimal. The contrast was nothing being used, and all the possible arterial accesses related complications were avoided. So echo-guided device closure advantages: only venous access, less time consuming, no dye requirement, less fluoroscopy time, minimizing radiation hazard. While disadvantage being complex PDA morphology difficult to assess, in adults difficult to get the views, where this TE guided could be a helpful, specifically when you have to get a closure in a pregnancy patients, not for the beginners. And transthoracic and TE guided PDA device closure is an option. Bedside procedures can be performed even in neonates, which is being performed in US and everywhere. Nowadays, catheter negotiating is an issue, but with practice can be handled. In congenital heart disease patient, imaging is very essential. Thank you.